Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's program is Clinical Updates for WINLEVI, Cream 1%. As moderator this evening, we have Dr. Naeem Issa, Clinical Director of Research and Academics, Forefront Dermatology, Vienna, Virginia. Assistant Professor of Dermatology, University of Miami, Miami, Florida, and Clinical Assistant Professor of Dermatology, George Washington University in Washington, D.C. Then as our speaker this evening, we have Dr. James Del Rosso. He is Research Director, Principal Investigator at JDR Dermatology Research, Las Vegas, Nevada, and Adjunct Clinical Professor, Dermatology of Touro University, Nevada, in Henderson, Nevada, and President of the American Acne and Rosacea Society. We would like to thank our supporter this evening, Sun Pharma, for making this educational event possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, please click on the phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. And at the end of the webinar, a survey will pop up in your browser and will also be emailed to you. We would greatly appreciate it if you could fill out this survey. And then within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. There will be time for a live Q&A at the end of the program. You are welcome to enter your questions in the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor to Dr. Issa.
Good evening, everybody. Thank you all for taking the time out of your busy end of the year schedule to spend some time with us, especially with Dr. Del Rosso, who, as you know, is a guru of all things acne and all things dermatology. So let's go ahead and advance the slide. So for those who are not familiar with this webinar, this is brought to us by the International Dermatology Education Foundation, also aptly known as the IDEF. And our president and founder is Dr. Leon Kirchik. As you all know, he doesn't really need much of an introduction. You see his face everywhere, and here we see him yet again. So we thank Dr. Kirchik for making this and providing us with a great venue to be able to disseminate medical and dermatology education. Next slide. And there's been numerous previous educational sessions throughout all of the dermatology space, such as looking at vitiligo, looking at hidradenitis, psoriasis, all sorts of medications, all sorts of data, and there will be more to come, so always stay tuned. And some ways you can keep in contact with the IDEF and also to look at some updates that are coming forward. They have an Instagram handle, they have a LinkedIn handle, as well as a Facebook handle shown here. And last but not least, there is a website shown at the bottom of the screen there that you could also access. Without further ado, Dr. James Del Rosso, who will take it away for clinical updates for WINLEVI clascoterone cream 1%. Dr. D, take it away.
Okay, thanks a lot, Dr. Issa. I personally very much appreciate that very nice introduction. I think it's great that we're both the warm-up act for Ashley, who was the first one on. She's the lead. She's the Adele tonight, and we're the warm-up acts. But Dr. Issa is also, in a much shorter period of time than myself, he's become intergalactic somewhat in dermatology. Does a lot of different things, and will be going back and forth on some of this with regard to acne, because he's very familiar with this, and we've worked on a lot of things related to this. By way of background, I have been involved with the development of clascoterone cream 1% with Cassiopeia, which is the parent company, and then coming to the United States through Sun Pharma, and have done some of the clinical research work on topical clascoterone, which is WINLEVI cream. And as you know, it targets sebum production. It's the first and only topical androgen receptor inhibitor. We've not had a topical androgen receptor inhibitor FDA approved for acne, and actually the only agents that we have that affect sebum production are oral contraceptives. There is oral spironolactone that is off-label, that is sometimes used, but that's systemic. This being only a topical, okay? So let me step back here, okay? So this is a promotional program which means it's not a CME program, so it's not accredited for CME. So we are required to stay within the FDA-approved labeling. I have received compensation from some pharma based on fair market value for the presentation, and that's all filed according to all the regulations with the government. And you can get copies of the full prescribing information, the package insert, by going to the website, or you can get them directly, obviously, online or through your representative. So we'll get started. We're going to be talking about something that a lot of people are not familiar with, and I wasn't familiar with it for a long time until I started getting into more about publications and education on acne pathophysiology, that we think about androgens, circulating androgens, what happens in the systemic circulation, especially after agenarche and certainly puberty, in both females and males, even though we focused on the hormonal aspects, if you will, of acne related to females, because we never had anything we could use in males. We couldn't use oral contraceptives or oral spironolactone off-label in males. But what is really, I think, even more important than that, because many times when you test females, especially adult females, their circulating androgen levels are normal, and you're wondering why they have acne at age 21, 25, 30, 35, because the skin, due to a variety of different things that can happen with the skin, with different enzymes and mechanisms that happen with actual androgen production by the skin itself, independent of circulating androgens. And that's very important. And that makes sense with having a topical agent that gets into the skin as a target organ without the systemic androgen exposure, or minimizing it as much as possible, which we do with proper use of WINLEVI clascoterone cream. And now that we have this ability to do this, with other agents that we have, which could be benzoyl peroxide, topical retinoids, topical antibiotics, and even some other agents that are out there, having a topical agent, and it's the only one that can inhibit androgen receptors and block sebum production and modulation by androgens, we now can target all four pillars of acne pathophysiology topically. So if we're utilizing clascoterone, and realize this would be part of the general standard of care, looking at acne guidelines, certainly not what's in the label, because labels look at monotherapy, but certainly the recognized standard of care, if you're combining it with benzoyl peroxide or retinoid, and let's say benzoyl peroxide or retinoid and clindamycin, which to me would be the most optimal, but there are certainly other options, you're addressing all four pillars of acne pathophysiology the first time topically. And then we'll get into clascoterone and then look at some of the efficacy and safety data, okay? So this is a very important slide. This came from a variety of references, but the graphic was from an initiative that I was involved in getting a group together, which included Hillary Baldwin, Zoe Drelos, you know, a few other people were involved. So we put this together to really outline the pathophysiology of acne and the skin as an endocrine organ. So what you're seeing is a male, and we put that being a Caucasian male, lighter skin individual, and you see a female on the left, a darker skin individual. So the point being, either gender, male or female, any skin color. So no one is immune to this. This is anyone, any race, color, or creed is affected by this. And certainly men and women produce androgens because they have both. I mean, men have more androgens, but women produce androgens by different mechanisms. Obviously, the gonads are different, right? The gonadal tissues are different, but they both have adrenal glands. So there can be circulating increases in androgens. But that's really not the usual process that you see. And many patients with acne don't have any increase in circulating androgens. So what you're seeing on the right is you're seeing that the skin within itself And it doesn't matter, once again, if it's male, female, any skin color, any race, color, or creed, the skin is able to produce androgens through different precursors, right? That are circulating but are not androgens. So they're, they can be cholesterols, they can be other precursors, but they're not androgens. So you have DHEA and DHEAS, but those have some androgenic activity. There are other non-circulating androgens. And then there are a variety of different enzymes. And some of these may have changes in their activity from one person to another, and that's been identified um, in the literature that can then create androgens within the skin. So the skin itself, and I'm emphasizing this because this is so important, can produce androgens that create acne, and circulating androgens from internal organs are normal. So that's the importance of being able to inhibit androgens in the skin, because androgens are the first step in stimulating acne lesion formation, not only early in life, but anytime a new acne lesion is developing in a pilosebaceous unit. And this is an extremely important part of it. Naeem, do you have any comments on that portion of the acne pathophysiology? Because I know we've talked about this in the past.
Right. So in clinic, the most common question that I get from, especially from female patients and the parents of these teenage patients, is that, is my acne or is my child's acne hormonal, right? They say, oh, the presentation of the acne more so on the jawline means it's more hormonal. But really, that's pretty much debunked given how we truly understand that skin is an endocrine organ, right? And exactly, without just reinventing the wheel of everything that you just said, is that aside from all the other hormone producing endocrine organs, the skin of itself is a bona fide endocrine functioning organ. And in the skin, there's many parts of the skin, from the hair follicle, right, to the keratinocytes. So there's numerous biochemical and biological studies proving that and making these precursors, right? And so eventually, like, what is the pathway, right, as you've alluded to, is that with having your sebocytes, you need to have some of that hormone that's locally acting there in order to produce the downstream four pillars that you're going to go into.
Right, and that's so important. I think the other portion of it is that pattern that we used to always think was related to, let's say, polycystic ovary disease or increase in circulating androgens, is only one portion of what's actually seen. Most, and this was based on data that came from large studies from Allergan back from the topical dapsone days, about 3/4 of the adult females that had acne, some starting in adulthood, many having it in the teenage years, and then having it come back later, did not have that lower face pattern. They had the typicals, papules, pustules, and comedones that you see just on the face, right? And so you can't put those patterns into necessarily, oh, this is systemic versus this is non-systemic. So I'm really glad that you brought that up. So we'll move on to the next one. So this is looking at when you activate androgen receptors, right? It shows what happens. So now we're talking about, you have the androgens that are going and stimulating the pilosebaceous unit, primarily the sebocyte, but does have activity on other cell types, like Dr. Issa mentioned. And this happens because the androgens modulate sebum formation, and they increase the sebaceous lipids that are forming the sebum. And that creates an environment that allows for proliferation of Cutibacterium acnes, which is the same thing when you see Propionibacterium acnes in the literature. And Cutibacterium acnes, when there are pro-inflammatory strains, because not all strains of C. acnes are pro-inflammatory, will induce different pathways of inflammation. And that's why if we use therapies to reduce pro-inflammatory strains of P. acnes, we definitely improve acne, but we don't get rid of it completely. That's because there's other pathways going on. There's actually cytokines that are produced by those stimulated sebocytes that also contribute to acne lesion development. And even though it doesn't really show it with a line directly here, there is also the follicular hyperkeratinization that leads to microcomedone and then comedone formation that are visibly non-inflammatory. And when we get to clascoterone, we'll see that clascoterone also reduces comedonal lesions. So there's a tie-in to activating the androgen receptors, getting the stimulation of the sebum, and then getting the acne lesion formation. So by reducing that activation of the androgen receptors, you're blocking that first step. And I am the first one to say I was guilty educationally when we talked about the pathophysiology. We didn't talk a lot about the androgen component because we didn't have therapies to bring into the discussion. So we only had a couple of things in women that pretty much very little was FDA approved and nothing topically that we could use that we knew that could be delivered safely and would actually do anything. Because if you compound spironolactone, you are based on no data that you're getting delivery or what you're actually getting in the skin safety wise or efficacy. That's not something I would do, right? Because that could be playing with fire if the patient's absorbing too much of an androgen, especially a female patient that might be pregnant, whatever. Excuse me. So I think that's very important. So
one thing I'll add, Dr. D, if real quick, if we could just go back to that one slide, and I think this is one amazing teaching point. That first line where activated androgen receptors lead to increased inflammation. So we weren't even taught that in medical school, right? That there's a direct relation with these androgen receptors. The way they work is that they come and they sit on top of the DNA and act as transcription factors.
right.
And they transcribe multiple different genes, right?
Cytokines.
Such as those involved in keratinocyte growth, sebum production, but also cytokines. And that blew my mind, when I actually first learned that.
And the data on clascoterone, the basic science data shows that it actually reduces some of those cytokines. I believe we'll be getting back to that a little bit later. So this is all very important. This is not just a smoke and mirrors, though topical clascoterone, it's available. There's science behind what we're talking about here, a lot of science. And there are several publications you can get that are available online that I've written some of them, right? So the 4 pillars, if you look at the American Academy Acne Guidelines for acne management, recognizes that there are many factors that go into managing acne, looking at the patient, asking their preference, diet, skincare, etc. But topical therapy is the foundation. Other than oral isotretinoin, there's really not systemic therapy that we will typically use without some type of topical regimen or using topical regimen alone. And clascoterone now allows us to address the androgen-induced sebum modulation or sebum production. When we say excess, it's over and above what would be the normal sebum production in that patient, because there's variations from patient to patient in the amount of sebum that they produce, right? So now we're looking at what the different agents do. So we're looking at that acne cascade. It points it as if there's a progression, that arrow going up. It's not a progression. All these things are going on simultaneously or near simultaneously in the pathophysiology, but you're looking across the top. So you have an androgen receptor inhibitor, and they have in the box WINLEVI, that it affects inflammation. Dr. Issa just emphasized importantly about blocking the cytokines and inflammatory pathways that come from androgen stimulation of the sebocytes and other cells, but also the C. acnes with the sebum that is allowing the Cutibacterium acnes to increase by modulating that indirectly by limiting the sebocytes, you could be influencing other inflammatory pathways. And then obviously on the bottom, reducing the stimulation of sebum and actually having some decrease in actual sebum production and sebum lipids. The hyperkeratinization, it's not checked off here, but you have comedone reduction proven in the clinical data, open and closed comedones with clascoterone. So it's influencing that, at least based on the clinical data. And then all of the other agents, whether it be topical or oral antibiotics, retinoids, which a lot of people will talk about, retinoids reduce sebum, they do not, right? There's no direct effect on topical retinoids we're talking about. Obviously, oral isotretinoin, but shuts down sebaceous glands, it's going to have that effect. But we're talking topical retinoids. Benzoyl peroxide is going to have impact on C. acnes and affect inflammation and other pathways. And azelaic acid, basically contributes. It's like that player off the bench that can do a lot of things for you, but it nothing other than the WINLEVI, the clascoterone, has effect on the androgen stimulation. So that's what makes it so important as addressing, no matter what else you use topically, you are not, if you're not using clascoterone, you're not addressing the androgen sebum contribution. That's really the bottom line of that. Okay. So now we have a video, and I'm going to ask Ashley to help us show this. Okay.
Acne vulgaris, a chronic inflammatory skin condition presenting as papules and pustules on the skin, is caused by the blockage and inflammation of pilosebaceous units, primarily on the face and upper trunk. Acne is triggered by an increase in androgens, whether due to circulating androgens or those synthesized within the skin. These androgens stimulate the sebaceous gland, beginning at puberty in both females and males. Androgens such as dihydrotestosterone, or DHT, bind to androgen receptors in sebocytes. The receptor then translocates into the nucleus, dimerizes, and initiates the transcription of androgen receptor target genes, activating the androgen sebum pathway. This increases sebum production and cytokine release, promoting inflammation. As a result of increased androgen activity, excess sebum serves as a nutrient source for Cutibacterium acnes, increasing proliferation and consequently inflammation and follicular plugging due to hyperkeratinization, leading to comedone formation. Androgen stimulation increases sebum production, initiating C. acnes bacterial growth, inflammation, and hyperkeratinization, resulting in acne vulgaris. Therefore, the androgen receptor in the sebaceous gland is an effective therapeutic target to inhibit the acne cascade.
All right. So we are now going to move forward here. Okay, so understanding clascoterone, here we're going to get into some of the basic science in vitro studies that were looked at to show that clascoterone actually does some of the things we're talking about. Because I know Dr. Issa is a very honest guy. I consider myself a very honest guy, but there's no reason why you should just directly believe us without looking at some scientific validity. And we got to give credit to our lead star, Ashley, for expertly delivering that video, because it's not always that easy to do. So when we look at what clascoterone is, it's a steroidal nucleus, which means it has that four-ringed nucleus, but it's not an androgen, right? It's an anti-androgen. It's not an androgen. It's not a corticosteroid. It's not like spironolactone, an aldosterone inhibitor, which also has some anti-androgenic effect. It's separate on its own. So when you see that four-ring backbone, there's a lot of compounds that have a steroidal nucleus, right? But that doesn't make them a corticosteroid. And we'll get to that a little bit later on what happens with clascoterone. So what clascoterone does is it competitively binds to androgen receptors, which dihydrotestosterone, which is the predominant androgen that can circulate and get into the skin or be produced in the skin, it blocks the effect of that dihydrotestosterone, right? So now you're looking at what clascoterone does. It established that it binds to the androgen receptors, and it also decreases, because when you had DHT bind to the androgen receptor in the cytoplasm, when they connect together, you saw them kind of hit together, and they goes into the nucleus, and that's, as Dr. Issa said, stimulates the genetic production of what androgen stimulation does, which includes production of the sebaceous lipids, and also several pro-inflammatory cytokines and other mediators. So the clascoterone is blocking that. So it inhibits the production of those target genes by binding to those androgen receptors. A lot of stuff is going on with genetics. It's really behind a lot of what's happening. So it binds to androgen receptors and inhibits androgen receptor activity, but they also have in vitro data, and you can get this directly from the company or from the medical science liaison from some pharma, to show that there's inhibition when they have a model where they have sebocytes and they introduce dihydrotestosterone, then in the presence of clascoterone inhibits that lipid synthesis, which is going to be a marker for sebum production. And then separately, they looked at the cytokine production to show that in those models, in the presence of dihydrotestosterone, you have the stimulation of those cytokines. Now you add clascoterone into that model, and that cytokine secretion is reduced. So there is the data to support what we're saying, and not just that theoretically we think it happens, we have proof that it actually happens. So any comments on that, Dr. Issa, before moving on to the clinical data? Because I know we're getting about halfway through, so we want to make sure we move along, but I want to give an opportunity to for people to hear the intergalactic dermatologist, Naeem Issa, right?
So my intergalactic answer to that is the mechanism is simple to understand, but simplicity is elegance. And that's why clascoterone is able to do everything you're about to state that it does. So we'll stay tuned. Thank you.
Okay, very well said. Okay, so we're going to move on now. And so this is from the important safety information that is a requirement to go over. And I think it's really important to state that there are no contraindications. So as long as you are using this for a patient with acne vulgaris, right? And this could be anywhere on the skin. It's not limited by any particular anatomic location. It's not limited by severity of acne. Could be mild, moderate, or severe acne. Now, be aware that in the clinical studies, they weren't patients that had a lot of nodules where you would be doing an oral isotretinoin study. But the classic type of acne where we look at topical agents with comedones, papules, maybe a few nodules, pustules, any severity of disease, and not limited by duration as long as acne is there, right? And applying up to 2 grams a day, 1 gram BID. You don't have to measure it, it's an approximate. So you're typically looking at a fingertip unit each time that you can thin layer apply to all the areas of involvement. That could be the face, and also it's not limited to the face. It could be regions on the trunk, not spot application, just thin layer regions. And as long as this patient is 12 years of age or older, you're on label. And there's nothing where they can come back and say you should absolutely not have used this, because that's what a contraindication is, as long as they have acne vulgaris on the skin and they're 12 years of age and older, right? So we are going to get into some of these other discussions. Pretty much you don't have any standout systemic safety signals in the studies that were anything beyond what you might see in the vehicle group, right? And so it's really potentially some local tolerability reactions that can occasionally occur and usually did not lead to discontinuation and could be relatively easily managed by good skincare. If you have a patient that's an outlier that has a significant reaction, then like anything else, you might not continue that with that patient, but that's going to be an exception. That's not something we typically see. We'll get into the HPA axis a little bit later. Hyperkalemia, the reason why hyperkalemia was considered was because of oral spironolactone and not knowing whether there was going to be some overlap by mechanism, but because of the limited systemic absorption and the fact that clascoterone is not an aldosterone antagonist by any significant mechanism, hyperkalemia going through stage 2, and hyperkalemia is just elevated above the upper limit of normal. Doesn't mean it was an alert or a major increase in hyperkalemia. It was very close between the active and the vehicle group. There was special analyses looking at that, dose response analyses, and the FDA determined there was no need to have any laboratory testing or do any testing of electrolytes, including hyperkalemia, after phase 2. So in phase 3 and post when the drug came out, there's no recommendation properly used, 12 years of age and older, that you have to monitor for hyperkalemia. That's very important. People get confused about that, and there is a publication out about that. I am the lead author if you want to look that up. And then we'll get to some of these other adverse events, which were tolerability reactions. If you suspect an event of some type that you think you want to report, you think it's significant, certainly Sun Pharma wants to hear about it. So this is very important. Remember, this is a monotherapy. These studies are monotherapy, and you're looking at investigator global assessment of getting patients to clear or almost clear, and they could have been starting as mild, moderate, or severe. They had a good, solid number of lesions at baseline in the study. And what you're looking at here is the trajectory of what happened in the blue, which is the WINLEVI group, and the gray, which is the vehicle group. Right? And you're seeing about a little bit more than 700 patients in both those studies. And you're looking at the trajectory of when patients got to clear or almost clear. And you're seeing that it takes some time. Think about the mechanism. This is not going directly within the follicle and changing follicular hyperkeratinization or directly reducing C. acnes where you might get a quicker visible effect on the acne. And even with the agents we have, even systemic agents, it will often take weeks before you actually see significant visible improvement. But with this drug, because of the mechanism and the steps we talked about, as a monotherapy, you're not really expecting to visibly see an effect that's going to be appreciated by the investigator and the patient till between week 4 or week 8, and sometimes after that. You're seeing it really kicks up after week 8. So respect what the drug is doing and what you expect it to do. You want to make sure a patient doesn't come back in a month and say, hey, this isn't working, right? And that's true of a lot of the therapies we have. But as people keep using it, and you'll see with the long-term data, you get more and more people that get better and better. And the vehicle does fairly well. It's a pretty well-designed vehicle, and we certainly want that. Sometimes you're utilizing a good vehicle or moisturizer, and I'm not saying this is a moisturizer, but it does not damage the barrier, which you'll see, and has a slight ability to increase moisture. That's something that we want. But the drug is substantially better than the vehicle. You're talking twice daily application. And those statistically significant evaluations are a p-value of 0.001. So that's very substantial. So that's really important. Now, if you're utilizing it with other agents, which is within your right as part of the standard of care and following the acne guidelines, maybe the patterns of response are obviously going to be different, but this is what the studies showed with what WINLEVI can bring to the table alone. Right? And now you're looking at the changes of the inflammatory lesion counts, the mean percent changes. The FDA required looking at that, and there was statistically significant difference for both inflammatory papules and pustules. They could have up to 2 nodules or none, no nodules. It's not predominantly nodular acne. It's your typical papulopustular and comedonal acne. And you're seeing comedonal lesions are what they call non-inflammatory. That means visibly non-inflammatory. So you also see those reducing, and you see that change starts happening after about week 8, where you get that separation. So it was consistent by IGA and by lesion reduction. So let's see here. Now you're looking at, let's go back. Now you're looking at 2 patients in the study. This points out you have a female patient and you have a male patient. Once again, that idea in people's heads that hormonal is only women. Men have hormones too, right? In case anybody didn't think about that. And we have androgens, we have estrogens circulating, but fortunately not as many, right? That separates some of the differences that you see between men and women. But look at the patient on the left at baseline, and we don't have the exact rating, right? Because this was captured earlier before Sun was involved, when Cassiopeia was involved, and we didn't have all the data on that. But I think it's important not to have it and think about what you would rate this patient. So this patient was rated, would be rated moderate. Some people might rate him as severe at baseline. And you're seeing at week 12, where would you rate this patient? Some people might have called them mild. Some people might have called them almost clear. If they called them mild, they would not have been considered a success in the study. But what kind of visual difference do you see as an investigator with a monotherapy? That's all that's being applied is the WINLEVI twice a day, right? And then you see the patient on the right, light skin, and you're seeing a male. He happens to be a teenage male. The female happens to be an adult female. So once again, it goes back to any gender, as long as they're 12 weeks of age and older, and you're seeing an appreciable difference clinically between the baseline and the week 12. And I think that's the important thing, because if you're looking at a chart or a graph, these patients might not have been called clear or almost clear, right? Some investigators may call them mild, some investigators may call them almost clear, and if the patient on the right didn't have any palpable lesions, that discoloration wouldn't necessarily be considered active acne. They may have been called clear, but it's what you're seeing, not what's going to fit into the bar and graph, because the FDA just wants you to report clear or almost clear, and that's going to vary based on the eyes of the individual. That's why it's important to look at these pictures and not just look at bar graphs. Bar graphs tell you only a part of the story, right? So now you're looking at safety, and you're seeing between WINLEVI and the vehicle at 12 weeks, the majority were mild. You had about 3/4 were mild, 1 out of 4 were moderate. There really wasn't anything that happened systemically in any of these patients. So when you look at nasopharyngitis, headache, sore throat, those are things that will often happen in both the active and the vehicle, especially if you're going through the winter part of the year, and you see it in both, and you don't see one sticking out more in one group than the other, and there weren't any severe adverse events. So there really wasn't anything that came out, and actually it was a little bit higher in the vehicle group. To me, they're essentially about the same, which is what we want to see. In the treatment emergent adverse events, that means it happened during the trial. It doesn't mean it was related to the drug or the vehicle. Could have happened anyway, right? So this is important. This is why they checked HPA axis suppression, because when clascoterone, when you actually expose it systemically, and this may actually happen within the skin, but we certainly know when they did evaluations in human plasma, it's metabolized to chlorhexidine 21-propionate, which is a mild corticosteroid. And it's there for a short amount of time. You see here that the majority of it is gone, the chlorhexidine 21-propionate, the majority of it is gone within 6 hours, and very little is trickling later. So we don't expect much corticosteroid effect, especially with the amounts that were evaluated in the trial. And that's one of the reasons why they included HPA axis suppression in the evaluation. That was done early on through phase 2. And the FDA determined there was a slight difference between the active and the vehicle. It was modest in only a few patients. It did not persist on retesting, okay, down the line. And the FDA determined it was not relevant, was very close between the active and the vehicle. And that was in patients 12 years of age and older that were evaluated. So there was no recommendation to look further at HPA axis suppression or to request any type of further evaluation of HPA axis suppression. But I wanted to make sure you knew why this was. Now, this question comes up a lot, and I'm sure, I know, Naeem, you must get this all the time. You know, putting something on twice a day is not as convenient, and they evaluated that. The clascoterone, it binds, but it doesn't bind irreversibly. So it'll bind to the receptor, but it will dissociate. And in order to keep those receptors loaded with clascoterone, in inhibiting the androgens, that you want that there as long as possible. So twice a day worked better than once a day, and it was significantly better. Once a day was effective to some degree, but twice a day works substantially better than once a day. That's why it's twice a day in the label. Right? So now we're looking at the local skin reactions, local tolerability reactions that happened in at least 4 out of 100 patients, right? And you will see occasional patients will get some erythema and some redness, which is typically trace or mild in the majority of these people. And it's usually transient and easily modulated with routine skincare in most cases. The same with the scaling and dryness. Occasionally some itching and burning and stinging, but those were fortunately uncommon. And they were actually seen a little bit more common with the vehicle in some cases than with the active drug. So there really wasn't much different. The clascoterone is not contributing to that, right? And so now, what about long-term extension? So the evaluations were done on the face, twice daily application. Nobody knew who was getting what. Okay, approximately 1 gram twice a day, right? And the lesion reductions that we saw were evaluated on the face. Then after 12 weeks, patients could roll over into the long-term extension. Not everybody necessarily want to do that, but a lot of people did. At that point, it's open label. Everybody knows what they're getting, right? So there's no vehicle arm. Now they captured investigator global assessment as the response going from week 12 to the end of 1 year. Right. So they're looking at investigator global assessment on the face, once again, thin layer application, and on the trunk. So from month 3 to the end of the year, they're now evaluating IGA on the trunk. That's why the label doesn't limit to only the face, doesn't limit to the anatomic location. So how did they do the long-term extension? Okay, patients had completed the first 3 months, and now you had patients 311 that had gotten WINLEVI, 289 that had gotten the vehicle. Now they're all getting WINLEVI twice a day. And if they got to clear or almost clear at any point, the investigator would stop the WINLEVI. If they were at least mild or worse, they kept the WINLEVI going. So they could start and stop, and the amount of WINLEVI that patients had to use over the course of the study varied from patient to patient, depending on whether their acne came back once they stopped the WINLEVI. Some patients may have had 3-4 months before they had to restart the WINLEVI. Some people may have been a month later. Remember, it's still monotherapy. They could not do any other treatment for their acne. No spa treatments, no lasers, no over-the-counter drugs. It's only the WINLEVI. And they evaluated that out to 9 months, and they looked at the face and the trunk. They evaluated safety, local skin reactions, any systemic reactions, but they're looking at clear or almost clear on the face and the trunk. The adverse event profile really didn't show anything different than what was seen in the first 3 months. So over the next 9 months, you didn't have suddenly, we're seeing an AE, especially something systemically that we didn't see in the first 3 months with the WINLEVI, but not something that that we saw in the vehicle group. So there were no new safety signals. The local tolerability reactions really fell out to be about the same in both the face and the trunk. They were lower on the trunk in most circumstances, probably due to the hardiness of the skin on the trunk. And remember, follicles are more spread apart on the trunk, right? And so you obviously have a difference in what's going to penetrate down into the follicle. Now on the face, this is important. As you keep utilizing it, you capture more people reaching clear or almost clear as they continue over the course of those 9 months on the WINLEVI. And half of them got to clear or almost clear by the end of the 9 months, right? The trunk is interesting. The trunk, they actually did a little better, right? And I think that might have to do with the density of follicles on the trunk. They're more spread apart. So there's less work that you have to do because these drugs have to work in every follicle, every pilosebaceous unit to treat what's there or stop what's going to come up. If you have less follicles, you have less, less follicles to be concerned developing the new lesions. But you can see here that a significant number of these patients had continued improvement, and they got better and better on the trunk that got the clear or almost clear. So the longer you use this drug, now remember this is monotherapy, the more people you capture getting further and further improvement, right? So the clinical updates, or any questions on that, Naeem, before on the clinical assessments here?
Not so much a question, but a comment is that that last slide that you just showed up to 9 months, I think shows a very critical aspect in terms of the MOA, right? Because here we're targeting a transcription factor. The androgen receptor, again, sits on DNA that affects the making of genes, right? And that biological function happens on the orders of hours to days. And here you're trying to shut that down. So you're not going to expect an overnight change, right? Because of that biology, this result is expected. It makes sense. And that's why we counsel our patients to expect this kind of result. And then before, one thing you noted in terms of severity and how severity of disease includes mild patients. And in order to be treatment success in terms of the global assessment, you have to hit 2-point drop. So not just clear or almost clear for those IgA2 patients, they have to go from a 2 to a 0. Right, and that's harder to do than going from a severe case down to 1, for example, be counted as a success. You couldn't have a single piece of acne. So we forget that concept, right? So that's why those pictures are so critical, as you mentioned.
And what you have to remember too, like you're saying, the timing, people started and stopped. So let's say they stopped for 2 months and they're restarting. They have to get that engine going again. That takes time to pick up and shuts off that genetic effect. If you were using it everywhere consistently and didn't stop when they got the clear or almost clear, I don't want to speculate, but you'd be blocking that engine over even more so over time.
Right. Dr. D, just to be respectful of time on my end here, we have just a few more minutes if we could kind of go through the remaining slides.
We're going to finish it up. We're going to finish it up. So this is very important. This is looking at the barrier effects. And this is a split phase study, 12 males, 38 females, 30 were white, 19 African American, one Hispanic, that used a 2-week split phase study where they're using WINLEVI on one side and leaving the other side untreated. And they're looking at transepidermal water loss and corneometry. They evaluated tolerability. There was one patient that unrelated had something happen, they couldn't finish the study. So they finished it in 49. The importance of this is they're looking at it not with single application, they're looking at it over 2 weeks because there can be some the unit variabilities when you're only looking at a short evaluation. And essentially you're seeing corneometry, which measures the amount of moisture within the skin. You want that to go up. And you're seeing at baseline, they were pretty much the same. The gray is untreated, the blue is WINLEVI. By 24 hours, there was an increase of moisture, and that continued throughout the course of the 2 weeks on the WINLEVI side versus the untreated side. Now, this data to me doesn't say, oh, you don't have to use moisturizers or whatever, but it lets you know you're not decreasing moisture, you're not having any barrier effect, and this is the full WINLEVI product. This is not just the vehicle. It's the WINLEVI product with its vehicle. And now you're seeing that transepidermal water loss did not increase. So there was no worsening of the barrier with the use of this product with twice daily dosing. This is very important data, right? Because you might be utilizing this with other agents, benzoyl peroxide, retinoids. It's not in and of itself compounding it because it contributes to barrier impairment. So no significant differences based on the investigators of the patients, evaluating the patients. The patients are obviously doing this when they're at home. The investigators are doing it when they see the patients. They don't see what looked dry, the skin didn't look tight, and the patients were not reporting any stinging, itching, or burning. So that was important also during the study. So in summary, we talked about the significance of the androgen sebum pathway in males and females, any race, color, or creed, approved age 12 and older for any place they have the acne, for any severity. They were typically moderate to severe in the study, but they could certainly have been mild, especially when they were going into the long-term extension. They had lesion count reductions and IGA success over the course of the 12 weeks and continued success over 12 months. Tolerability was overall very favorable. No systemic safety signals that stood out, specifically related to WINLEVI when it's properly used, and skin barrier integrity and moisturization were sustained. So I'll stop at this point. This is basically the same thing I said earlier with the important safety information. No contraindications, local tolerability issues can occasionally occur, and HB axis suppression and hyperkalemia were evaluated, but were not felt by the FDA to go beyond phase 2 for evaluations, no laboratory assessments in the package insert. So I think that was all very important. So we'll stop at this point and see what questions people might have, right? Right. So Dr. Issa, let's see what we have.
Okay, so first question from the panel here. Is there any effect on male teens' beard development?
So in the studies, that wasn't drilled down specifically and looked at, but there was nothing observed or anything that patients said that I was aware of. And I looked at the formal study report that the FDA had, and there wasn't anybody saying, hey, I think I'm having an effect on my beard growth or on my hair growth on my face, or even in the females in the study. So it wasn't drilled down as a special interest effect in these studies, but there was nothing reported in that regard that I'm aware of.
Right, and something to also consider is that this is not permanently blocking the function of androgen receptors, right? This is a small molecule with a contact time there.
Right.
So this is restoring homeostasis, right?
Right. And it's not binding and sitting there for days and days and days. That's why it's a twice daily application. Right.
Exactly. Another question. What is the category for pregnancy and breastfeeding women?
There's no pregnancy categories anymore. So the recommendation would be very similar to topical retinoids. It would not be something that you would recommend to women during pregnancy or breastfeeding. It's not listed as a contraindication, but I think it would just be wise to take that approach.
Right. And I always tell patients if they ask me about this, or my colleagues, I say there is no pregnant or breastfeeding subjects that were enrolled. And
Exactly.
so hence with that, if you're going to be a purist, there you
Right.
go.
Yeah. I think
Actually,
that's very important. They wouldn't have
right.
been in the study. Right.
Exactly. Actually, one question that I had, and I think is very critical in this modern day and age, are those that are undergoing gender-affirming transitions or surgery. Do you think that clascoterone is actually fulfilling an unmet? Let me rephrase this. What are some unmet needs in acne treatment that clascoterone is fulfilling?
Well, if they have acne, right? Now keep in mind now, they're undergoing they're on agents that are accentuating depending on what direction they're going and how much they're taking. That is stimulate. So it's like a drug induced. They may have acne vulgaris, but it's accentuating that. It how it, that was not studied in these trials specifically to look at the efficacy, but if you're determining that the patient has acne vulgaris, I think it's certainly reasonable to utilize it, but we don't have data to know based on these clinical trials how effective it would be. But I don't think there's any reason why you wouldn't use it if they're getting androgens, increased androgens as part of
Right.
the process.
Absolutely. In my practice, actually, I'm using it without even second guessing my choice,
Right.
given the safety profile and the efficacy profile. And furthermore, for male patients, and I think it's not just my opinion, but probably a lot of those who are listening, and including yourself, is that, male patients specifically, these patients are not getting spironolactone or oral
Well, that's the
contraceptives, right?
point. That's why
Exactly.
we didn't talk about it, and that's why
Exactly.
people don't think about it in males.
Hmm.
Prescription patterns show people are still thinking more of females. It's equal.
Hmm.
Males have acne by the same mechanism as females. So it's
Exactly.
equal gender, usage. No
Right.
reason why you should use it only in females or less in males.
Right.
Exactly.
And Dr. D, so there's an interesting question posted here is that, well, given the importance of, of hormone signaling in acne and we've known this for possibly decades with, spironolactone being used in the early 1980s even, right? Why is it that there has been a dearth in topical drug development of anti-androgen molecules? I'm a little bit
There-
younger
There's,
than you, right?
there's multiple tries to do it.
Uh-huh.
It's been extremely hard. There are a couple that were available in Europe, but there was significant concerns about the systemic androgen exposure, right? And
Hmm.
so it was very difficult to be able to find an ability to get penetration
Hmm.
into the skin with limited systemic exposure. There's been a lot of look at topical spironolactone, and they haven't been able to get a formulation where they can have that tight control where what's happening systemically. And that's why, I mean, it's really a crapshoot, and I think a significant risk. And I'm surprised there's not a drill down because the companies have to do so much work to
Hmm.
prove that they're getting concentration in the skin and not having the systemic exposure and adverse events. Generics that are used out there, not for this, but they have to prove some level of equivalency. But compounding pharmacies, nobody's looking at what they're doing. And we're giving this to patients knowing nothing about what's happening to them. I think
Right.
that's a problem.
Right, right. And then we have time for one last question since we're rounding out at 8 o'clock. Is this safe for concomitant application of this medication with tretinoin?
Okay. It was only evaluated off label, right? That being said, there has been evaluation with admixture studies with some agents like benzoyl peroxide and tretinoin that are available on file that shows no breakdown of clascoterone when exposed to those other agents. Not in the label, but that is available that you can access through the company.
Right, and in my personal practice as well, because of the fact that there's no drug-drug interaction and there is no chemical rationale that one's going to oxidize or break down the other molecule, I am using concomitant therapy
Well,
off-label.
I think a lot of people are using concomitant therapy, but you don't
Yes.
know with benzoyl peroxide about
Mm-hmm.
how close together. In vitro admixture, benzoyl peroxide did not degrade clascoterone.
Mm-hmm.
So we know that.
Fantastic,
We know that.
fantastic.
And that's available through the company, through the medical department.
Fantastic. Dr. D, thank you so much for your expertise and giving us a lively and lovely lecture. And major thanks to Sun Pharma for providing this wonderful molecule, clascoterone, also known as WINLEVI cream, 1% to be used twice daily for ages 12 and up for our acne vulgaris patients. And thank you all for attending this evening. We appreciate your questions. We appreciate you. And we look forward to future sessions with IDEF. Here's one that's coming up on December 10th with Dr. Lisa Swanson on counseling a patient with moderate to severe atopic dermatitis. Y'all have a lovely evening and good night.
Great. Thank you very much. Thanks, Naeem, and thanks,
Thank you.
Ashley. And thanks, IDEF.